Our plenary session. Sorry that we're a little bit late. This is because the opening part took a little bit longer than expected, and hopefully you have had a chance for a small break here. So my name is Risto Miettunen. I'm president of the IHF, and I will be chairing this session. We have excellent speakers and panelists, and let me introduce them to you. We will first of all have a video speech from Dr. Bechara Chukar, who's a vaccinations coordinator at the White House in the US. And after that, we will have 4 other presentations. And let me introduce to you, first of all, to Dr. Natasha Azzopardi-Muscat. She's Director of Division of Country Health Policies and Systems at WHO Regional Office for Europe. Then next to her, we have Wright Lassiter III. Wright is the President and CEO of Henry Ford Health System in the US, and will be talking about American perspectives. Next sitting is Bertrand Lebrun, who is Chief Executive Officer at Geneva University Hospital, Switzerland. And our 4th speaker will be Professor Josep Campistol, Chief Executive Officer at Hospital Clínic, Barcelona, Spain. They will all introduce their topics as they speak. So very warm welcome to you and also the speakers and panelists. A technical note for the run of this session is that we are planning to have a questions and answers session only at the end. So we will hear these 5 presentations in a row, and we have enough time at the end to have questions and answers. So for that purpose, please use the Congress app. We will not have questions from the floor, but they will be entered into the Congress app system, and we will be able to see them and then conduct the discussion according to them. And this applies both for you who are here present, but also those who are following online. So for the questions and answer session at the end of this panel, we will use the Congress app. Warmly welcome. So let's get started. We will have the first video presentation from the White House, Dr. Bechara Chukar. Please.
It is such a privilege to be able to speak with you all today at the 44th World Hospital Congress. I was hoping to be able to join you all in person in Barcelona, but given all that is going on in our vaccination effort, which I'll be covering shortly, I'm joining virtually from the White House here in Washington, D.C. I want to start by relaying the enormous appreciation I have for all the work you do and for the critical role hospitals across the world have played in responding to this COVID-19 pandemic, from caring for the critically ill to administering therapeutics, tests, and COVID vaccines. You have all been at the front line of this pandemic. You have witnessed unprecedented illness and death and sacrificed tremendously. You do have my sincere gratitude for all you have done and will continue to do. Today, I'll be discussing the US vaccinations effort, how we have approached the effort, what we have learned as we think about future pandemics, and the critical role hospitals, their leaders, and their staff have played. We all know our global vaccination effort is our most important tool to protecting ourselves and our loved ones and to allowing us to put this pandemic behind us. Vaccines are enabling us to spend more time face-to-face, go back to school, eat safely at our favorite restaurants, and return to work with our colleagues. They're helping our economies to keep moving, and they are allowing us to hug our loved ones without fear. We have to ensure vaccines are widely available. And so I'll start there on vaccine access and vaccine equity. This has been our priority from day one of the Biden-Harris administration. When we came into office back in January, we set two objectives: to get shots in arms as quickly as possible and to do so as equitably as possible. As a country, we leveraged partnerships between the federal government, state and local governments, the public health community, and hospitals and health systems to pursue these goals. We provided billions of dollars to state and local governments so that they could stand up their own vaccination clinics. We helped tens of thousands of hospitals, doctors' offices, health clinics to do the same with funding and technical assistance. We stood up high throughput mass vaccination clinics nationwide. We shipped vaccines directly to tens of thousands of pharmacy stores and to community health centers across the country, which provide healthcare to our most underserved communities. Vaccinations were being administered incredibly quickly in the first 4 to 5 months on that effort. And the partnership between government and healthcare providers was driving remarkable results. By the end of May, almost 175 million people in the United States had received at least one dose of the COVID vaccine. But even as we prioritized our initiatives to promote vaccine equity in the rollout, racial and ethnic vaccine disparities persisted. And at this point, the pace of vaccinations overall started to slow as we had reached most of the individuals eager to get a shot, and we're now primarily focused on reaching people who are less confident in the vaccine. So in those months leading up to and after May, the pandemic response transformed from what we called an all-of-government response to more of an all-of-society response, where we also activated businesses, large and small, community and faith organizations, public health leaders, inspiring figures. And we doubled down on efforts to activate local clinicians nationwide who communities and patients know and trust. So I'm going to give you a couple of examples. To improve access and make it even easier for everyone to get vaccinated, we made sure there was a vaccination site within 5 miles of 90% of the people in the United States. We helped hospitals across the country offer vaccinations upon patient discharge and at emergency departments. Notably, in the United States, emergency departments serve as the primary and unfortunately often only healthcare access point for up to a fifth of the population. That includes a number of vulnerable groups: immigrants, persons experiencing homelessness, people living in poverty, and the uninsured. Offering vaccines at emergency departments is critical for these folks. We also deployed tens of thousands more pop-up vaccination clinics at community-based organizations, faith-based organizations, schools, business sites, sporting events, and barbershops. Uber and Lyft offered free rides to and from vaccination sites. Childcare was offered for free to watch kids while parents go get the shot, which was especially critical in low-income communities. And we asked businesses to offer paid time off to all individuals to get vaccinated. Second, we placed a huge premium on building vaccine confidence by launching a nationwide grassroots network of local voices and trusted community leaders to encourage people to get vaccinated. We rolled out public ad campaigns about the vaccine and elevated trusted physicians and community leaders as vaccine ambassadors on local radio and local TV, and deployed billions in funding to support local community efforts to educate about the vaccine. More recently, our vaccinations effort have focused on 3 areas: vaccine requirements, boosters, and preparing for approval for vaccines for 5 to 11-year-old, all while making sure that our top priority remains vaccinating the unvaccinated. On vaccine requirements, we have encouraged and facilitated vaccine requirements for all U.S. government employees and federal contractors, for all healthcare workers, and for all companies with more than 100 employees, whose employees will need to get vaccinated or tested once a week. These vaccine requirements cover over 100 million workers in the United States. And before we announced these requirements, it all started with vaccine requirements that hospitals and health systems announced on their own, including the US Department of Veteran Affairs, the largest health system in the country, and thousands of hospitals nationwide. The leadership on the vaccine requirement provided by hospitals across the United States, as well as the support of the American Hospital Association, were critical in setting the stage for the national vaccine requirement strategy that President Biden announced. I spoke with hospital CEOs across the country, and I'll be forever grateful for that leadership. Turning to boosters, for individuals who received their second Pfizer or Moderna COVID-19 shot 6 months or more, they are eligible in the United States for a booster shot if they are 65 years and older, 18 plus with an underlying medical conditions, 18 plus who work or live in high-risk settings. And for the nearly 15 million people who got the Johnson & Johnson vaccine in the United States, booster shots are also recommended for those who are 18 and older and who were vaccinated 2 or more months ago. And eligible individuals may choose which vaccine they receive as a booster dose, or as some people call it, mix and match. We have already gotten more than 20 million booster shots in arms, and hundreds of thousands of additional Americans are getting boosters each and every single day. So we will continue to administer boosters to our eligible populations. Now, turning to pediatric vaccinations, we have been preparing for the regulatory approval of the Pfizer vaccine for 5 to 11-year-olds by the FDA and the CDC for weeks now. We secured enough supply of the Pfizer vaccines. We prepared to make pediatric vaccination accessible and convenient across the country at over 20,000 locations, including pediatricians and family physicians' offices, children's hospitals and other hospitals, pharmacies, community health centers, and school-based community sites. We are also preparing to launch a national public education campaign to reach parents with accurate, culturally responsive information about the vaccine. And this campaign is investing heavily in trusted messengers, including thousands of local community and faith leaders, schools and state and local health departments, and national community organizations. Notably, this campaign relies heavily on pediatricians, family doctors, and other healthcare providers, including hospitals and hospital leaders, to be messengers. And even as we execute this plan at home, we continue to support global efforts because we know this virus does not respect any boundaries. So we're proud to have donated over 200 million vaccines to over 100 countries, more than all other countries combined. And we've announced we will be donating over 1.1 billion COVID vaccines overall, with a focus on donating them to lower income countries in need. So what did we learn and how can we leverage the lessons from the COVID-19 response to strengthen health systems and pandemic responses of the future? Our public health infrastructure has been overstretched in the United States. Our data systems for disease monitoring and sequencing needed to be improved. Historical health inequities in our country have been exacerbated in many ways. We have already made significant investments to address these issues. We are investing billions of dollars to hire and train public health workers who live in the communities where they serve. We are building genomic epidemiology infrastructure to prevent and respond to future biological threats, and building a national bioinformatics infrastructure to create a unified system for sharing and analyzing sequence data to enable informed decision-making. On top of this, we have made historic investments in enhancing and securing supply chains in vaccines, PPE, ventilators, testing, and pharmaceuticals. Importantly, we've put our money where our mouths are, and I think it is the most important lesson for us all on a global scale. We want to ensure positive health outcomes in the long term and not be flat-footed when the next pandemic comes, which it will. One other really hard-hitting lesson we learned during the pandemic response was about health misinformation and the distrust some people feel of health and government leaders. The fact is, while 80% of US adults have received at least one dose of the COVID vaccine, recently progress has been slow, and getting each incremental 1% of the population vaccinated is harder than the last. This is because of distrust. Some of it justified due to historical health inequities in our country, and it's also because of misinformation. We hear misinformation about the vaccine all the time in the United States and all over the world about microchips and infertility and dozens of other unsubstantiated rumors. It spreads by word of mouth and by social media. It also prevents people from getting a shot. It is critical as we think about health crises and the pandemics of the future that we are prepared to address people's distrust and concerns. And we are responding head on to the misinformation people are hearing from a listen first, empathetic perspective. Importantly, the people best equipped for addressing concerns and countering misinformation are the folks in each of our immediate communities. First and foremost, the medical professionals at hospitals and primary care practices. Survey after survey shows us that local medical professionals are the most trusted source of medical and vaccine information. And we also know this to be intuitively true. And also from community leaders, family members, and friends, partnering with those medical professionals and amplifying their messaging. The fact is, people trust people they know, the people who've proven to be trustworthy and dependable in their communities, and they trust those people far more than they would trust government officials. So I ask you to make sure your hospitals are equipped to proactively be public health ambassadors in your communities in the years and decades to come. Your voice is essential. And I'll wrap with this. I believe we have the tools to end this pandemic. Now we just have to finish the job with truth, with science, with resources, with confidence, and most importantly, together as a global community spanning public and private sectors, academy, industry, and the healthcare community. I thank you all for your leadership, your sacrifice, and your dedication to that aim.
Thank you. Am I on? So thank you. We just heard the message from the White House. Unfortunately, Dr. Bechara was not able to come here in person, but we will continue with the public health aspect. So as next, I would like to ask Natasha to take the podium, and she will share if the next pandemic is already around the corner or what to expect and how healthcare systems in Europe will respond and what's needed to improve the response. So Natasha, please.
Thank you very much, Risto, and good morning, Excellencies, ladies and gentlemen. And I think in the opening sessions earlier today, we really heard a lot about how hospitals have been very much at the heart of the pandemic and how the pandemic has exposed gaps in hospital structures and the wider health systems. Probably we can all agree that whilst we are still very much in the throes of this pandemic, this will not be the last pandemic we face, and now is the time to prepare. And I was asked to talk about how can we make our hospitals and health systems better prepared and more resilient. Let's start with the good news. The good news is that we now already know what makes for a resilient health system. It was just days into the pandemic when, with our colleagues in the European Observatory for Health Systems and Policies, we set up the Health System Response Monitor to document live as countries were responding, to be able to learn from each other and to be able to share best practices. And what can we say? We can say that those countries that were more resilient really were able to employ very early on a dual-track approach. On the one hand, surging and responding to COVID. On the other hand, not neglecting that there were essential health services that had to be maintained. The second point is really to recognize early on the need to care for the health workforce, particularly for the mental health and well-being of the workers to minimize stress and burnout. Third, there were health systems that found ways immediately to deliver using multimodality platforms. And this, of course, needs to be strengthened going forward. But this was far more possible in those health systems that already had good infrastructure and that had invested early on in systemic interoperability, particularly between their hospitals and the wider networks. And fourth, we saw how hospitals came together, countries came together to buy and secure the supplies that they need to make sure that supply security, production, manufacturing capacity was tackled early on. How did this happen? This happened better in those countries where there was attention to governance, to coordination, where there was strong public health leadership based on accountability, communication, and trust. So this is really a moment of opportunity now to rethink how can we make hospitals more resilient. And here there is one mistake that we need to avoid. The mistake would be to really have siloed thinking, focusing narrowly just on preparedness and response from an emergency perspective. Why? Because we have saw through this pandemic that you really need to be working through all the three pillars of WHO's General Programme of Work and European Programme of Work. Namely, you need to have an eye on universal health coverage to ensure that you reach everyone, particularly those most likely to be left behind, as we have just heard from the previous speaker, who explained how they are reaching out to make sure that everybody can get vaccinated. And then the third pillar, which is focusing on health and well-being. We can't, in the face of a protracted emergency, and we don't know when the end is in sight, to lose sight of the health and well-being, but we also will be better prepared to address the next emergency if we have a population that is healthier, and that during the context of an emergency does not actually experience deteriorations in their health and well-being because of increased risk behaviors. We saw increase, for example, in uptake of alcohol, domestic violence, and a large decrease in mental health and well-being, particularly in children and adolescents. At WHO, we have prioritized 4 flagship areas, and I think that all of these are really relevant for hospitals as we go forward. Mental health, and here again, I talk about the mental health of the health workers and their families. That's really a sizable chunk of our populations. The digital health, the need to seize the moment. A lot of money is being invested in digital health systems, but we want to make sure that this is not just supply-driven, but very much need and demand-driven. And here we look to you all to be articulating the needs of today and the needs of tomorrow. The behavioral and cultural insights that links very much to what was said by the previous speaker about trust, building trust in the communities and understanding our communities. And our 4th flagship area is immunization. And of course, I don't need to dwell on that point. I'd just like to share that these areas were actually selected before the COVID pandemic broke out, but we just realized how important they really are. Of course, we didn't wait to start thinking of the recovery, and as the regional director, Dr. Hans Kluge, said earlier in his address today, already a year ago, he convened a commission to rethink health priorities in the context of pandemics. And the report that has been published in September, Drawing Light from the Pandemics, makes 7 key recommendations. One of these is, of course, strengthening the resilience of our health systems. And next Monday, with our partners, the European Observatory on Health Systems and Policies, we will be convening the DGs and chief medical officers from the 53 member states across the region and launching a book on resilience, but also, more importantly, trying to find practical ways about how we can have more resilient health systems as we face the upcoming winter. So, where do we go from here? I think we want to really see hospitals and hospital networks as key players in the wider health agenda. The first objective of the Pan-European Commission on Health and Sustainable Development is really to take a One Health approach. I did not project the slide on the new determinants of health in the first century, because in order to include them all, the text is so fine. But I would invite you to really read our report and to look at the wide plethora of determinants of health. What is driving those people that come through your hospital doors? And we see hospitals as being key players in the larger whole of the recovery, not only focusing on the human factors and animal factors, but very much also on the environmental factors too. Because of course, hospitals do play a very important role in rebuilding the economies and societies of the communities in which they are embedded, as well as an important role in dealing with the environment and the carbon footprint. So I would like to end with an invitation to all of you to work with us hand in hand to enable us to understand better your needs, to shape together going forward a new agenda for hospitals based on the lessons learned from the pandemic, just as we have done at our last regional committee, where we have shaped our thinking on primary healthcare systems based on the lessons learned. Initial thoughts would be clearly we must take much stricter approaches to infection prevention and control. And this means also really thinking about who needs to come to the hospital and who can receive care elsewhere. The impact of digitalization, big data, and AI, we are just sitting on the cusp of what could really be a revolution, but it will be a positive revolution if it is steered to address need and demand. Really knowing our communities and reaching out to those who are most vulnerable and most marginalized to make sure that we close the inequality gap. And finally, appreciating the impact of hospitals on the economy, society, and the environment. I'm confident that working in partnership with you, we will be able to really ensure that our hospitals are far better prepared when the next emergency strikes, as no doubt it will. And I would like to thank you all for giving me the opportunity to share my thoughts with you on behalf of the WHO Regional Office for Europe. Thank you very much.
Thank you. Thank you so much, Natasha. And just as a reminder, we will have the opportunity for questions and answers after the speeches. So now we are going to move from the public health aspect to the world of hospital CEOs. And first I would like to introduce Wright to take the podium. And we are thinking of the role as CEO in the middle of sort of a triangle, having the patients and population at one corner, the staff on the other corner, and then regulators and authorities on the third. So the CEO typically finds himself in the middle of this. And we will hear the US perspective, also later on European perspective. So Wright, please, the floor is yours.
Thank you very much, Risto. Good morning, everyone. It's a pleasure to be here with you on behalf of the American Hospital Association and Henry Ford Health System. And as Risto indicated, what I hope to do is to briefly share a quick story on who Henry Ford is, for those who are not aware of us, and then talk a bit about how we responded to the pandemic in the United States. And what you'll hear, I think, from my discussion is not dissimilar from what you heard from our White House vaccination coordinator as you listen to his conversation around how the United States is responding to the COVID pandemic. Just to begin, let me just share very quickly a bit about Henry Ford Health System. We're an organization that in the United States, it's called an integrated health system. And what that means is that we attempt to offer both the delivery system aspects of healthcare, hospitals, physician offices, surgery centers, those things that patients come for service, as well as the risk financing part of the health system. And so we have a large insurance company as well that has about 650,000 lives covered. We're an organization that's about $6.5 billion in revenue on an annual basis. As you see from our quilt here, you see the number of physicians, not quite 6,000 physicians across our system. We have a large academic presence as well, a large teaching hospital based in Detroit, Michigan, where we receive about $120 million a year in research funding from the NIH and other sources. Heavily involved in research, both related to COVID and outside of COVID, and also very heavily related, focused on delivering care in broad communities, vulnerable communities in cities and in rural communities, and doing that both through our brick and mortar facilities as well as digitally, as you'll see about 6 million digital encounters last year. As we think about COVID for us, COVID hit the state of Michigan last March. And so we were considered a early hotspot in terms of our COVID infection. And so as you see by our graphic here, we began standing up what we call our Incident Command Center, our system-wide Incident Command Center, the first week of March, as we saw colleagues in the state of Washington and the state of New York beginning to receive significant COVID volume. We were sure that we were not too far from that same calamity. And in the second week of March, the first COVID patients hit the state of Michigan. March 14th, first patients hit our healthcare system. And we frankly went from 0 COVID patients to about 900 in our hospitals within about 3 weeks. And that was, as we look now at our fourth wave of COVID, that first wave was our most intense. As you look across our key milestones, you'll see several things that were of significance for us. We began as the first healthcare system in the state of Michigan to be able to do COVID testing with our pathology and laboratories in-house so that we could quickly process patients coming into our emergency departments, et cetera. We then began deploying resources throughout not just our hospital system, but working in significant cooperation with the mayor of Detroit, with the governor of the state of Michigan to support the response both in the city and in the state. Our head of infectious disease served as the advisor for the city of Detroit's mayor around their response. And I had the privilege of serving on the governor's task force looking at the state's response to COVID. And then across the spectrum, we went through the cycles that most of you have experienced. Large volumes, significant volume in our intensive care units, significant volumes of patients on ventilators. We went through scenarios where our state and many states across our country required our hospitals to terminate any non-emergency activities, and so we went through significant periods of time where our organization was, frankly, in crisis, responding to the public health crisis around us. As you look at a quick quilt on our COVID journey, just to give you a quick sense of patients admitted in our hospitals since last year, lives saved. When we first began doing this, we began tracking lives lost because there was so much trauma and drama related to COVID. But we began to think that it's really more important to talk about all those that we saved, which are far more than those that were lost. You see the number of tests our lab produced during that time. Our system participated in more than 200 research studies and trials trying to assist in advancing the response to COVID with both treatment and then with vaccine trials. You see vaccines administered both to our team members and to the broader community. And you also see things that you might not expect from hospitals, things like distributing masks to broad communities. In the United States, in the midst of the COVID crisis, we also had some very significant racial strife throughout our country with significant protests related to police behavior. And so we spent time trying to make sure that in the midst of a COVID crisis that people weren't transmitting COVID in the middle of their protests by distributing masks in many places. And you'll also see that we, in partnership with the federal government, were one of the first to begin administering monoclonal antibodies to the broad community. And so you see the significant involvement there. When we talk about COVID in our organization, we talk a lot about we're on a journey from pandemic to endemic. I think, as we all know, when you think about the etiology of viral transmission and of public crises like this, You know that this won't just go away. While as our White House coordinator indicated that we have the tools to combat and to stop the pandemic, what we fully expect, not unlike the flu, COVID-19 virus will remain in our society, and the question is, how well do we manage it? This graphic just gives you a very quick sense of, the purple shows you case counts from the beginning of the crisis till now, and the green shows vaccination support and where our organization has been. I would say that today we are in sort of our fourth wave of COVID. We consider a surge any scenario where we have more than 100 patients across our system. As we stand this morning, we have just over 200 patients in our system, and so this is our lowest wave thus far of the four we've had, but we still see ourselves very much in the COVID crisis, and are hopeful that the efforts at the state, local, and national level will bring us out of the crisis. As we think about how we've tried to support our communities, what's really important in the role of hospitals is certainly not just to serve as emergency department locations where patients come, not to serve as places for research, but also to serve as an extension of our public health infrastructure. Would say that certainly in the United States, public health is thought of a little differently than in Europe and other parts of the world. I'm a big proponent of greater emphasis than we currently have in our country for public health. I would say that in most communities around the country during the crisis, most health systems have taken on a role that's broader than they imagined. Most health systems were not in the vaccine business pre-COVID. Many health systems were not doing community outreach at a very neighborhood level pre-COVID. Many are doing that at this time. And so I would just say that we have found that when you think about things like starting up field hospitals in your city because you believe that your hospitals will be out of capacity, something that we did with our federal government and our Army Corps of Engineers, that was not something that was sort of in our playbook pre-COVID. And we've certainly found that our role has been expanded, and we've been excited to do more to support the community and to support particularly vulnerable communities and communities where there are significant health disparities in our country. As you've heard from other speakers, would just say that when people ask me what am I most concerned about with the COVID crisis today, the answer isn't caring for COVID patients. The answer isn't the science that provides treatments or vaccinations. What concerns me the most is the wear and tear on our frontline workers, the folks who have been the heroes during this time. As a measure that we thought was protective of our employees and our team members, we were the first healthcare system in the state of Michigan to require that all of our team members be vaccinated. We made that stance. I took that stance June of this year. At that time, we had about 60% of our staff that had been vaccinated. Our vaccine requirement went into place in the middle of September, and happy to say that at this moment we are at 99% of our staff that are vaccinated. And so we've been very both excited with the response, not only within our own organization of 35,000 individuals, but across our community and across the country as we attempt to get more healthcare workers vaccinated. As I indicated, the impact really is lasting and strong and long with healthcare workers and with our healthcare system. I could spend this whole talk just talking about the amount of revenue that U.S. hospitals, including my own, lost during the COVID crisis. For us in 2020, it was about $600 million. Throughout the entire crisis, we will see revenue losses of about $1 billion as we have dealt with responding to COVID in various different ways. But it's not just the financial impact of systems, it is the resilience drain on our workforce that continues to be of significant concern. And we just say that our organization, as many in the United States, have doubled or even tripled their resources around employee assistance programs, around resilience training, around therapy for our team members in an effort to try to stem the significant impact that we see for our workforce. And then let me just close as I see our time coming to an end by talking about a couple of things that we learned from this setting. What we learned, frankly, was that global supply chains were not as robust as we thought. Our organization, as many around the United States, have made investments in PPE companies so that we would never be caught off guard like we were last March with concerns about having masks, N95 masks, gowns, gloves, et cetera, not available. And so our organization has joined a number of others in ensuring that we have the kind of supply chain support that our organization needs. In addition, we've done things as we've looked at how the crisis has impacted our team members. We've raised salaries at what we call in the United States a living wage commitment to ensure that our lowest paid workers do not suffer economic hardship during times of significant economic hardship. And so we've continued to do things that we hope will be lasting for our team members and our organization and our community. And the last I would say is this: I show you this picture, a sunny day in Detroit, because I believe very strongly that while we've been in some dark days through the COVID crisis, that we see very bright days in front of us. Our community, our state, our nation is one of resilience, as are many of yours, and we look forward to using the innovation and the strength of our workforce to continue to fight this challenge going forward. Thank you very much for your time this morning.
Thank you so much, Wright, for sharing your experience. So from the CEO angle, we are moving to the other side of Atlantic. So I would like to invite Bertrand to take the podium and talk about the European experience.
Well, Mr. President, thank you. Hello, everyone, dear colleagues. It's a pleasure being with you today. I'm the CEO of Geneva University Hospital, which is called HUG, which I find quite a nice word for a hospital. Some politicians in Geneva call it huge, it's true, but HUG I definitely prefer. We faced the COVID pandemic like all of you. We have a 2,100 bed hospital, and at the moment we have more than 5,000 people who pass through with COVID disease. We have two particularities which I wanted to stress. First of all, as all of you, we learned what a real curve and an exponential curve was. Before, maybe it was just theory, but we all, as my colleague just said, in 3 weeks' time, we passed from 0 patients to more than 700 in our hospital. So it had to be a huge turnaround, and everyone responded present, and I must say it was really impressive. The second thing, which is here on the slide, is that I heard yesterday we want to be the first in class for IHF. Well, we were the first in class in Geneva, or the last in class, because we were the epicenter of the epidemic in Europe for the second wave. The Swiss-German part of Switzerland said it was because it was the Swiss-French and they did not abide to the rules. But more seriously, it was most probably because Geneva is an international city with a lot of people going around, and that made us under a prodigious and tremendous challenge to respond to the crisis. And last but not least, and you see it here on the graph, I have almost 5,173, to be precise, employees who live and are French citizens. So while everyone was talking about closing borders, I was fighting hard to make the borders open and to keep them open during the crisis. It is a structure that we have since many, many years, more than 15 years, where Geneva, it is a bit of particularity and a historical one. Geneva has 105 kilometers of border with France and only 4 kilometers of border with Switzerland. So we're very particular, surrounded by France, and a lot of people live in France, buy things in France, come in Geneva to work, and it's true for the health workers as well. And during a pandemic crisis, we had a very big particularity in Geneva to maintain the border open for professionals, but also to maintain the border open for patients. And I must say that what pandemic taught us and what we managed to do in a matter of days usually take almost a decade and numerous groups of working groups and task force and whatever. But there, during the crisis, we managed to live as a real environment that is cross-border environment. And I'm looking forward to hear to our colleagues from Luxembourg later in the day, which experienced the same thing, being not just a country, but being a region that has to have logical way of finding solutions as a region. And you know that Switzerland is a very decentralized state. We have 26 cantons, so we have 26 health ministers in Switzerland. And in France, you have Paris deciding for the rest of the country. So we had to find a balance and really to work very specially in Geneva about maintaining borders open, and it did bring as well some interesting solutions. I've been asked to talk about patient, staff, and public health authorities and this triangle in which we are. So I will talk about patients because we all say patients are first. Well, what about patients? And what did we learn about patients? Well, first of all, as it has just been said, some patients did not have COVID disease, but we had to cancel their operations. We had to communicate with them about priorities we were making. And basically, yes, of course, it was patients first for the emergency, but for many others, it was tough and difficult moments. And the second thing, even though we did develop, because we're a rich country with a lot of possibilities, we did develop telemedicine, possibilities to reach your relatives through a screen, etc. But we did have, especially during the first wave, some people who died alone in a hospital, not being able to speak with their relatives, and the relatives not being able to be close to their loved ones when they were at the end of their lives. And we all experienced this. And I'm struck today, and I would like to stress this as a message, I'm struck today that not everyone has passed to the new life, being that it's a fundamental human right for a patient to be visited by as many relatives as he or she wants. And a lot of our hospitals, they reopen only for this rule, like one visit for one patient, one day. And why that for? Why did we step back? Why aren't we, like we are today in this auditorium, being able to have a QR code, people screening in the entrance, and making it possible through tools and processes to have this fundamental right of being visited again by as many relatives as you want. And since we are talking about being prepared for the next pandemic crisis, well, let's be prepared never to have this happen again. It's a matter of organization, it's a matter of possibilities, and we have the technical possibilities today, all of us, to make this possible. So let's together make sure that for the next pandemic, we will not have to close our hospitals again to relatives, because even though, yes, we made huge progress in telemedicine, yes, definitely we made huge progress in the capacities to not be physically in the hospital, but nothing replaces the possibility to be close to your relatives when he is passing away. Second, with the staff, and with the staff, I'm very glad to come after what you said. The staff did an extraordinary job, and we can only be with a lot of recognition on what has been done, but the staff has suffered a severe toll, and is still suffering a severe toll. And as I am a Swiss citizen, you know, in Switzerland, we vote all the time, we ask people, so I will ask you to raise your hand, responding to one question I have. How many of you think, I will first say all the questions, and then you can choose when you raise your hand. How many of you think we will lose in the coming 12 months 0 to 5% of our personnel? How many of you think it will be between 5 and 10? How many of you think it's between 10 and 15? And how many of you think it's over 15? So let's have a vote. As a Swiss citizen, I'm always very keen to take opinions of others. So who think, and please raise your hand, we will lose in the coming 12 months 0 to 5% of our staff? I don't see any hands up. Who think we will lose between 5 and 10% of the staff? Who think we will lose between, what did I say, 10 to 15%? And who think we will lose more than 15% of our staff? Interesting enough, I think this is the elephant in the room. I think this is what we have to talk about, because we know that the coming months, the coming years, will be under tremendous pressure for all of our system, our health system. And we also know that by seeing your hands being raised, I see the majority is between 10 and 15% of the staff being going away to other issues, etc. And even if you're the best CEO in the world, well, maybe you will reduce from 1 to 2% this percentage, but you will not prevent a major crisis coming up, which is that we said first, we're going to run a marathon, and please be resilient to run a marathon. Then it was not a marathon, it was an ultra trail, and now it's full of uncertainty, and we still don't know exactly where it will end. So I think there we have a real task to do, to know how we can care more for staff, how we can arrange society as a whole to really make a difference. I've heard with great interest what we could do to promote women leadership, and I'm sure that this is one of the ways, but also to promote possibilities for women to work in a hospital, whatever their life is, and how to make the system evolve to be different. Then finally, the public health authorities. Well, it's all about trust. It's all about the possibilities to share a vision and to uphold the vision. I was talking about the borders being opened. We maintain the borders open for the French citizens who were sick so that they could be hospitalized within Geneva University Hospital. And of course, once it comes to difficult moments, when it comes to making choices on patients, to uphold the vision, to uphold ethics, and to say that there will be no difference on race, on sex, on social origin, and there will be no difference on nationality, and that our hospital will be the one taking all the patients. It's easier to talk about it today in Barcelona than at the moment, even though it was very easy because it was values. And I think with public health authorities, you have to keep the trust, keep the values, and keep the certitude that whatever the crisis, it comes to an end. And when a crisis comes to an end, it determines how you live together afterwards. And there in Geneva, we had the chance to be aligned and to be together. French authorities, Swiss authorities, to be sure and to have this certitude that a crisis comes to an end one day and we will have to work together. By authorities, I would like to stress out that some disappeared, and as a CEO, it was not totally a shame that they disappeared during the crisis. I'm talking about all the regulators, all the auditors, all the people whom every day of your life as a CEO, you spend like 20% of your time justifying what you do and not doing the business. Well, during the crisis, they were not there. They're back, all of them. But I would like to pledge to, again, imagine organization around purpose and just to reflect on the fact that maybe some of the controls are not always as necessary as they seem. And finally, one drawing from a Geneva cartoonist, Josep, whom I like very much. Of course, we know the solution is about vaccination. But on the other hand, in Switzerland, we have a very poor rate of vaccination. We're only at 64% of the population. It's not about accessibility. It's not about anything else. It's about relationship to power. As Swiss citizens, we vote all the time because we don't really trust the authority. And so we keep a very liberal and independent and individual responsibility on people. And the second thing which made Switzerland is the respect of minorities. So we do respect one another all the time if you have a different opinion. And that's why we have Swiss French, Swiss Italian, Swiss German together, which is always sort of a miracle. It's because we respect minorities. And today, with almost 35% of people not wanting to be vaccinated, it is a real challenge for Switzerland and for the years to come to know what kind of language we can have to both respect minorities, but on the other hand, be sure that we are on the public health side with clear response to vaccination. So I thank you for your attention. I'm looking forward for the debate because I think we all face the same problems and we all have our ways of finding solutions. But I would like to stress again my respect and thanks for the health worker, for you, all of you, during this crisis, because I think we demonstrated as well that one of the things which we often hear, that younger people do not feel they have the same drive or will as others, is totally false. What we experienced during the crisis is that all the health workers, all of them, even though all of them were afraid of dying sometimes or bringing back the virus home, they all were there. Whatever the job they were doing, from the janitor to the surgeon, they all responded present. And I think this, and you all responded present, and this deserves a real appreciation and applause. Thank you very much.
Thank you, Bertrand, for sharing your experience. So we're going to continue with the CEO experience, and I invite Josep to take the stand. He's going to have a slightly different aspect. As a CEO, you have to get your staff prepared and educated for future situations. So his talk will be on demands of clinical professionals. Please.
So good morning. Thank you very much, Risto, and thank you very much to all of you to be here, and welcome to Barcelona. It's a great pleasure for me to be this morning with you, and I'd like to thank the organizers, and especially to La Unió, to really give the opportunity to our hospital to be present in this interesting meeting and in this interesting conference. As you know, we are trying to see how will be the next, which will be our role and our work in the next pandemics. And that's the two questions that the chairperson gave to me. What we did in the past, what we did in this pandemic, in this SARS-CoV-2, in this COVID-19, and how we prepare for the next pandemics. First, let me try to introduce our hospital. Probably some of you know our hospital. We are in the downtown Barcelona, maybe 5 blocks from here. We are really a sanctuary hospital. It's a public hospital, and we have a very important problems of a space. You can see here that this hospital is surrounded buildings, and buildings, so we don't have a space to do anything except to treat and to take care of our patients. Just to share with you, that's the numbers, the big numbers of our hospital. We have close to 900 beds. We discharge approximately close to 50,000 patients per year. In the outpatients department, we see more than 500,000 patients. In the emergency room, in a very small place, we see more than 100,000 patients per year. We did approximately 25,000 surgery per year. We work in health workers, approximately 5,000 workers, and we have a budget over 550 euros. That's the situation of our hospital. How was the pandemic in hospital Clínic? Here you can see the first slide with the big numbers. We have in the patients more than 5,000 patients, and probably 3 times more in the emergency room. So altogether, it's around 14,000 patients in the emergency rooms and around 5,000 patients in the hospital. Here in this slide, you can see the different weights and also the mortality rate, which is around 10%. So altogether, it's around 600 patients which died in the hospital related with COVID. Here you can see the 5 ways that we suffer, especially the first one. The first patient arrived in the hospital in February 24th, 2020, and until 3 weeks ago, we received patients. Here you can see the 5 waves with a different intensity, especially the first one with really very important and very sad. But at the end, the 5th wave that was really recently this summer was also quite strong, although the profile of the patients and the mortality rate was significantly less than at the beginning. Especially in the first wave, we completely changed our hospital. In red stops, it's the waves that were COVID positive. As you can see here, approximately 80% of the hospital were COVID positive, and that include all kind of wards in the hospital, all kind of emergency rooms, and also many surgery rooms, many theater in our hospital. So 80% of the hospital at what time was COVID positive. At the same time, we need to open, just 3 blocks from the hospital, a health hotel with approximately 300 patients at the same time. So altogether, in the health hotel, we take care around 800 patients. But at the one moment, there was around 300 patients and approximately 700 patients in the hospital. We were prepared to open a health pavilion, but at the end, the things were a little bit better, and we didn't need to open this pavilion to take care of our patients. We did a lot of research. We start approximately 200 projects on research related with COVID on different points, related with disease, on research, on vaccination, and also research on immunity. We did a great job on vaccination. We administered approximately 50,000 of doses of vaccine, different types of vaccine, first to the professionals of the hospital, Around 95% of the professionals of the hospital are correct vaccinated, and also we vaccinated different kind of chronic patients, including transplant patients, oncological patients, and also lung patients. How we can do that? I think that's very important. We did that because we work as a team. Apologize, that was in Catalan, but I want to share with you that I think we did a good job because we work as a team. Teamwork was essential during the pandemic, and I want to share this slide with you. I think everybody was important at that time, from all the hospital, all workers, physicians, surgeons, nurses, everybody was crucial, and everybody really did a great job during the pandemic, during the fifth wave that we suffered. So if we want to summarize how we did and how we solved the situation, I think we are a quite good hospital, so we have a good clinical preparation, but probably more important than our preparation is the values that we use and we introduce in our hospital. Values like generosity, solidarity, teamwork, trust, gratitude, and modesty. That was crucial really to do a good job to really answer the very important point that we have, especially in March and April of 2020, and really to do a good clinical work to our patients. So values were crucial at that time. So now we need to see and we need to prepare for the new pandemic. First I crossed my fingers and I tried to say that we don't suffer a new pandemic, but probably we suffer a new pandemic. I don't know if it will be in 1 year, in 3 years, or in 10 years, but I think it's crucial as a health system and as a hospital to be prepared for the new global pandemic that probably will suffer in the future. And I have 2 slides. One is for the health system, that will be in Barcelona, in Catalonia, and the second slide will be for the professionals in the hospital, but health professional. By the health system, I think the crucial thing, and I like to say one of the other speakers, we need infrastructures. We need modulated hospitals. As I mentioned, you can see our hospital. It's a hospital with more than 100 years of history, very fixed, very rigid, and that was impossible to work. So we need new infrastructures with the modulated hospitals. The second important point in these modular hospitals, I think it's crucial to be a change from ICU to ward units, and also to have some isolated rooms, especially for infectious disease. So that's another important concept that needs to be introduced in our hospitals. Important thing, we need a digital control of the hospital. There needs to be a tower with cameras, with different things, and need to be in a real time. How is the situation in all the hospitals, in all the world, in emergency rooms, in the intensive care units, in all the world. So this digital control of the hospital in a centralized way, I think it's absolutely crucial. We need an integrated health system, especially with IT. I know that there is difference from the primary care to the hospital to other partners of the health system, but I think it's crucial to have this integrated health system. Very important, we need to introduce artificial intelligence in the hospital. We need to process our data. We have a lot of data, but we need to process, and artificial intelligence needs to be in and needs to be worked in the hospital. Very important, we need a unique health control in the region, in the country, and this unique health control needs to be scientific, needs to be technical. We don't need the politicians do our job. We need to do our job because we know how to do, and that's a crucial point. Needs to be scientific and technical. We need a political consensus. I don't know how it is in your country, but I can tell you that was a lot of difficulties here in Catalonia, in Spain, about the political consensus and how we deal with the pandemic. And finally, and that's crucial for the society, we need a good communication policy. That's a very important point. The society needs to have a clear ideas what they can do, what they cannot do. And that's crucial to do a good job on communication to the society. And finally, about the professionals, of course, we need to have a technical and clinical education. with a good training, with a good preparation. That's essential all around the world, in all around the system. Important point. The second point, for professionals, we need a fast and easy and global communication. Very important, like the society, for our organization, for our professional. But finally, and probably as important as this, we need to instill values in our organization. We know and we learn the importance of values during the pandemic, and the gratitude, generosity, trust, teamwork, and transparency needs to be in our organization if we want to be prepared for the next global pandemic. That's all I want to share, and I want to thank you for your attention and to thank to all the health professionals here in Barcelona, in Catalonia, and all around the world for their extraordinary job. Thank you very much.
Thank you, Josep, and thank you all for your excellent presentations, really. Now we have some time for questions and answers, and I would encourage you to use the Congress app, both here in the room, but also online. It's available, and I will be handed a tablet here where I can see your questions. So this is how we're going to do. So please think about your questions, and before we get into those, I just would like to advertise a bit. After lunch, the next plenary will be headed by Natasha. We will talk about vaccine development and research issues. So that is not really a question, but just to invite you after lunch to follow the next plenary. But I have a question of my own. I would like to address it to the CEO panelists. So now thinking of this learning of a global pandemic, which is a crisis situation, as we heard, and it's a lot about resilience, how to cope with all the problems. Is this some relevant learning for other situations, maybe like natural disasters, wildfires, nuclear incidents, massive refuge, things like that? Are there lessons to learn from here? So, right, please.
Yeah. So, thanks for the question. First thing I would say is, as we talked about, as I talked about our incident command structure, I think that's a key learning for us. In the United States, there's generally a requirement that hospitals plan for mass casualty events and for mass events, and generally speaking, hospitals do that independently, even when they're part of a system. You have a hospital-based incident command center. As it related to this pandemic, we, for the first time in our history, had a system incident command center that coordinated with each of our hospitals, incident command centers in various communities, and we have taken that collaborative structure, and we have created models for how we would use that for other events. And I think that for us, it was probably the best example of collaboration, teamwork, transparency, broad communication on a constant basis over an extended period of time. And so our sense is that process would allow us, if there were any kind of emergency that impacted a large region that we were a provider for, that we could use that same structure to support our response.
Thank you. How about Bertrand?
Maybe on the same subject, but I was struck by the fact that all hospitals are prepared for the plane crash, for the train accident, for the huge fire, because we know it's one event and that it will stop. We were, and I was reflecting to you saying we need to know what's going on in our hospital in real-time situation. We were just struck by the fact that we were lacking instruments to predict what would be the situation in our hospital in 10 days' time, because we were having to run after information all the time. And I'm really confident that this crisis enabled us as well to reflect on the need to have some better data to be able to lead the reflection and the organization forward, and not to just respond to the emergency crisis, which we usually are organized to face. And there, we're still a bit poor about this. And when I listen to the news or to the medias in Switzerland, we're still reflecting on what's going on today. But for hospital managers, this is not the issue. The issue is how is it going to be looking like in a week or in 10 days' time? And there, to have proper data and to share this data and to have the same capacity to reflect, analyze, and take decisions on what should be the case in society, but also what should be the organization inside your hospital to be always having a few days of advance. This, I think, we learned and we have to integrate for the future.
Thank you. How about Josep? What's your view?
I think, as I mentioned, I think the digital situation in the hospital will be absolutely crucial. To have a digital control of the whole hospital will be really very, very important. We have a lot of data, but this data needs to be not to see what happened in the past, needs to predict. But again, values, in my opinion, could be absolutely crucial. I think that the pandemic was very strong for all of us. There is a very high index of burnout. And I think if we want to prevent this burnout in all the professionals, including physicians and including nurses, I think we need to go and we need to work with values. I think that's my recommendation, and that's what we need to do in our hospital, still in a public hospital here in Barcelona, in Catalonia.
Thank you. And lastly, I would like to ask Natasha for your opinion in European context. We see a lot of cross-border movement, and also we see a lot of hindrance there, people not being able to move freely in a situation that could be related to something else than COVID, and not going into detail of what the reasons are. So in terms of public health, what kind of challenges do you see in moving cross-border? We do have a lot of borders in Europe.
I think this is an area where it took time to get us coordinated, and that there are still many much potential for improvement. It's always important to, of course, balance people's individual rights. I think we had an excellent case study presented from our colleague here, situation with Geneva and France, but also as WHO, sometimes we even struggle to get humanitarian teams where we need them to be. So there's clearly lessons to be learned, but I think this pandemic has shown us that it is possible within a relatively short period of time to introduce systems that talk to each other. And today I think we somehow take it for granted that if you want to cross from one country to another, you have to present some kind of verification, something which perhaps a year ago there was still a lot of even discussion about, and whether this is something that would be accepted by the population. So I think that it was very important. If I may, just on a personal note, I think I was very much struck by the way in which our presentations, be they from the hospital perspective, from the wider public health perspective, have really converged on a number of key issues. So I think that we have touched upon really what needs to be done to strengthen the resilience. They are not easy issues, particularly I think the one around the health workforce and the burnout and the attrition, and whether we can attract young people to join, or whether other sectors are going to be able to offer them work-life balance and working conditions that are far more attractive. So I think this is a hard nut that we still need to think about more together.
Thank you. So now looking here at my tablet, I have no further questions. So at this point, and probably lunch is waiting, so this might have an effect here. So first of all, thank you to all our panelist speakers. Excellent discussions, and thank you for being here and attending, and also all of you who are online. It's been a great session to experience. So I would like to inform you just to share your key takeaways and bring it to the Congress app. So you can discuss there and social media about the experience we have had here. So please use it. This session is recorded, and it will be available in the event platform in a few hours. So it's reachable for 1 month from here. So you can have access to that as well. So thank you very much. We move to lunch. We will have a lunch break, and enjoy also networking and the exhibition in there. We conclude here and reconvene at Natasha's next plenary. Thank you so much.